Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. Today, I will be discussing about hepatic cysts. So, basic objective will be to gain some information on differentiation between benign, inflammatory, and neoplastic cysts, role of imaging for specific diagnosis, and at the end, pathology. So, based on etiology, hepatic cysts are basically divided into infectious and non-infectious. And these non-infectious can be further subclassified as benign, pre-malignant, malignant, and traumatic, while as obvious infectious can be subdivided into parasitic and non-parasitic. But in actual practice, in a preoperative setup, the division is typical or simple cyst and atypical cyst. So a typical cyst is basically a clear fluid line which is lined by a single layer of biliary epithelium. As we can see here on the imaging, these are basically round, pencil sharp, and there is no capsule. The content is basically serous. And as we can see on the histopathology specimen, these are a thin membrane, and on histopathology, it is lined by a single layer of biliary epithelium. Now, anything that is not typical is basically atypical. So, various features that we'll get is irregular and wavy margins, thick capsule, shaggy inner margins, solid portions, presence of septa as we can see in the images, typical cyst in cyst appearance or multiloculated appearance. Why are we so much worried about atypical cyst? Basically, it's all about a few new things, that is the mucinous cystic neoplasm. So there are few worrisome features to diagnose the mucinous cystic neoplasms. Major worrisome features like thick septations or nodularity, and minor worrisome features like upstream biliary dilatation, thin septations, internal hemorrhage, perfusional change, or less than 3 coexistent hepatic cysts. So as we can see in the images, in image first one, as we can see, it is a capsule-lined cyst containing nodularities, enhancing nodularities. In the figure B of T2 weighted MRCP, we can see a thick septa, while in figure C, again a T2 weighted MRCP, we can see a thin septa, while in the final histopathological specimen, in a cyst, we can see a nodularities. Now coming to, there has been various controversies about diagnosis of biliary cystadenoma and cystadenocarcinoma. Before 2010, any mucin secreting cystic lesion was diagnosed as biliary cystadenoma, and which led to lots and lots of misconceptions, and basic data was getting skewed. So in 2010, WHO classified these mucin secreting tumors based on the presence of ovarian stroma and connection with the bile duct. So any mucin secreting tumor having ovarian stroma was classified as mucinous cystic neoplasm, while it was essentially absent in a intraductal papillary neoplasm, just like IPMN. And above that, these intraductal papillary neoplasm were in connection with the biliary system. So I'll try to explain it. Basically, the first figure is of a simple cyst. Here we can see a cystic cavity lined by a single layer of biliary epithelium, which you can see in the lower histopathology diagram also. Okay, and for MCN, as we can see, this is a thick capsule lining the mucin secreting tumor cells with a septa and the typical cyst in cyst appearance. On histopathology, we can see these are the ovarian stroma. While the third category, that is IPNB, we can see these are the papillary tumors without any presence of ovarian stroma. Now we'll go into the imaging of a mucinous cystic neoplasm benign type. So in the ultrasound, we can see there is the presence of septa in the cyst. While on a contrast enhanced CT, you can again see these septa traversing the cyst. Again, in the MRCP, you can see the multiple septa that are crossing the cyst. On the gross specimen, we can see thick capsules with a nodular tumors within the cyst. And in the final histopathological diagram, as we can see, these are lined by biliary epithelium with presence of ovarian stroma. The ovarian stroma in this case is not in the whole of the specimen, but ovarian stroma for diagnosis doesn't need it to be lying extensively. Any presence of ovarian stroma is a diagnostic. Now again coming to a mucinous cystic neoplasm that is malignant. Here we can see these are capsule-lined cystic cavity with a peripheral line nodular lesion with calcification. You can see on the top there is calcification and another small nodular lesion which doesn't have any calcification. In figure B, the ultrasound image again shows presence of nodular lesions with calcification in the periphery. On the histopathological imaging, again we can confirm with presence of ovarian stroma. Now coming to next diagnosis, that is intraductal papillary neoplasm. So like pancreas, the intraductal papillary neoplasm of biliary tract was given by WHO, and these are based on morphology divided into 4 types: polypoidal, mucosal spreading, cast-like type, and cyst-forming type. So for our differential, we are concerned mainly with the last one, that is cyst-forming type. In these tumors start forming at the periphery of bile ducts, and that leads to ballooning of the bile duct. And that presents as cyst. As we can see in the contrast enhanced CT and MR, that there are cystic lesions associated with the biliary tree. And in the gross specimen, we can see this red arrow shows main bile duct intraductal papillary neoplasm, while these smaller arrows are showing smaller cystic lesions in the peripheral bile duct. There is another entity which is quite analogous to the branch duct IPMN of pancreas. These are tumors which develop in the peribiliary cyst, as these are still in connection but far away. That's why they are considered analogous to branch duct IPMN. So I'll show a gross specimen. In this, as you can see in the CT images, there is a cystic lesion lying in association with the biliary hilum, and the specimen was removed along with common bile duct. And on histopathology, as we can see, a papillary lesion without any ovarian stroma. Now, how to differentiate MCN from a cystic IPN in a preoperative setting? So there are few peculiar features which will help us in differentiating between them. First is septa. Septas are quite common in MCN, but they are not seen in a cystic IPN. Cyst in cyst appearance is very typical of MCN, especially benign MCN, while these are never seen in a cystic IPN. And bile duct communication is never seen in an MCN, and by definition it should be present in all the cases. But on preoperative imaging, we are able to appreciate in only half of the cases. Hydatid, as my next speaker is having a full topic, so I am not going in detail. But many a times, hydatid being a multi-chambered, multi-septated lesion, and especially in an endemic area where serology is negative in hydatid in almost 40% of the cases, many a times a biliary mucinous neoplasm is missed, and only on pathology we get to know that the diagnosis was a biliary mucinous cystic neoplasm. A pyogenic liver abscess is relatively easier to diagnose, especially in patients having clinical features. On imaging, you will get a double or triple wall with a multi-chambered necrosis, presence of shaggy margins with enhancing thick septas. Now, this was a paper about amoebic liver abscess from our institute. Generally in amoebic abscess, we get a subcapsular single lesion with ragged edges and many times rim enhancing rim enhancement along with occasional septas. A polycystic disease, basically by definition, polycystic disease is told to be when there is more than 10 cystic lesions. All the lesions are similar to a simple liver cyst in which the cystic cavity is lined by a single layer of biliary epithelium. So on imaging, we will get the features of a simple liver cyst. Only thing is that whole liver is covered with a cyst. Carelli's disease and Carelli's syndrome, basically these are diseases of abnormal involution of embryonic ductal plates. So these lesions are in line with the peripheral biliary ductal systems, and whenever in a Carelli's syndrome, portal vein is lined by fibrotic tissue, so that gives a central dot sign. Many tumors are very peculiar for giving cystic metastasis, most common of which is mucinous adenocarcinoma of colon, followed by ovarian cyst adenocarcinoma, neuroendocrine tumors, GIST, melanoma, breast cancer, renal cell cancer, and in fact, any rapidly growing metastasis can present with a cystic lesion. Here we see a cystic neuroendocrine tumor. Basically, for a cystic neuroendocrine tumor, the tumor should be rapidly growing so that there is a ischemic necrosis at the center that presents as a cyst. But the periphery of the cyst will always retain its typical features. Like in a cystic neuroendocrine tumor, the periphery will always be enhancing in the arterial phase. Same way, in the cystic degeneration of HCC also, the periphery retains its early arterial enhancement and delays portal venous washout features. Although it's easier said than done, they can be highly confusing. Now coming to the management portion, first we have to look for any complex features. In the absence of complex features and with diagnosis of a simple cyst, we have to decide whether the patient is symptomatic or asymptomatic. In asymptomatic patient, we need not do any intervention. In fact, according to the latest EASL guideline, these patients need not be followed also with any kind of investigation. Once these patients turn symptomatic, then only volume reduction therapy can be given, which can be in the form of aspiration along with sclerotherapy or fenestration, and occasionally with the presence of complicated resection may be offered. Now coming to a complex cyst, these patients need further imaging, and once with a diagnosis of mucinous cyst, the treatment options that are possible are resection versus enucleation. Now, as of now, the gold standard is resection, but there is no head-to-head trial comparing resection with enucleation, as the total denominator for any study is very low. And based on the final histopathology, if that was a R0 resection, then nothing more to be done. Now, in the end, I'd like to give you a case capsule. That patient came to us last month. So this was a 9-year-old female child who had a history of sudden onset of severe abdominal pain 1 year back, which followed a fall from bed. She was evaluated outside in a different institute and diagnosed to be having ruptured liver abscess with sepsis, for which she underwent diagnostic laparoscopy followed by lavage and drainage with deroofing of abscess cavity. In the post-op period, she had high output biliary fistula, and for which she was stented after 2 weeks. After stenting, her fistula resolved and her stent was removed after 2 months. Patient recovered well. Her final histopathology was biliary epithelium with ovarian stroma. Now after 1 month, she has presented to us with abdominal discomfort, minimal sort of pain, and a recurrent cyst involving segment 4. Now in this history, I have highlighted all the red flag signs. She was a female, as she had a bile leak, so she may have had a bile duct communication. Her histopathology was suggestive of ovarian stroma. Since this was a 1-year-old, so we didn't get any slide for review. And now recurrent cyst. So this was the imaging that we got. In her ultrasound, as we can see, there is presence of capsule, but no septa was there. Same was the features in the MRI and contrast enhanced CT. There, it was not a simple cyst, that we were sure, but no other complications were seen. On
I
CT
think
as
you have to cut short this summary.
sorry.
Cut it short.
Okay, just last slide.
Okay.
So, as we can see, this cyst was towards the left of middle hepatic vein. So, we plan to do a left hepatectomy in this patient, considering her age and all the red flag signs. Now, intraoperatively, she had a left lobe atrophy, which was, and the cyst was in fact extending up to the right side in the segment 5 also. So we went ahead with left hepatectomy along with enucleation of cyst in the segment 5. As you can clearly see, the enucleation is very clear cut demarcated, and her histopath was even more strange. That was epidermoid cyst. We confirmed that with immunohistochemistry as well. So pathology can be very strange at times. In conclusion, cystic liver lesions has a spectrum from benign to pre-malignant to frankly malignant lesions. Most lesions are benign and asymptomatic and requires no intervention. Large symptomatic or malignant cysts need evaluation and management. Accurate preoperative diagnosis is essential for appropriate treatment. Pre-malignant cysts are rare but pose diagnostic and therapeutic challenges. Thank you.